Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. You know, we did a show a few months ago talking about neurologic intervention, new surgical techniques. We had such a response. There were so many questions that I thought we'd go back to the well. And here they are, right in front of me. So let me introduce first Dr. Brian M. Snelling, Dr. Snelling, who is a neurologic surgeon and can't get the word, so you tell me.
Cerebrovascular
neurosurgery, cranial neurosurgery, endovascular neurosurgery. So you got the whole gamut. Welcome.
Yep. Thank you so much for having me.
Good to have you. And Timothy Miller. He's a neurological surgical expert. He does a lot of brain surgery, I understand, and functional neurosurgery and spine surgery.
Yes, sir.
So good to have you, sir.
Thank you. Thanks for having me.
First, we're very enthused about the new, in my mind it's new, the Marcus Institute of Neuroscience at Boca Regional Hospital. And I guess it must be exciting to you both as mature but young physicians who will have at their hands and their brains the opportunity to use the finest of equipment and new techniques that come out of your mind. So, Dr. Snelling, let's talk about that, if you don't mind.
Sure. You know, I think it's exactly as you had mentioned, through the generosity of a lot of benefactors, not only Mr. Marcus, but other benefactors in the community. You know, there's a world-class, state-of-the-art facility that allows treatment of the entire spectrum of neurological diseases, not only things that I focus on like stroke and cerebrovascular disease, but also Dr. Miller's specialty of functional neurosurgery and spine surgery and things like that. So again, through that generosity, there's been the infrastructure that that's allowed the treatment of all of these diseases that certainly affect our community.
You know, Dr. Miller, we got into the conversation the last time we had colleagues of yours on this program, because you know the folks out there who ask questions, because it's really their show, they ask questions about minimally invasive techniques, and I can't think of anything that's more minimally invasive than the neurologic surgical techniques. Although we have advanced so dramatically in orthopedics and cardiovascular disease and things of that nature, but when you really think of it, what you're involved in is very interesting to the folks that are viewing us. So let's talk.
Yeah, that's a really good point. Minimally invasive means a lot of different things to a lot of different people. In the realm of spine surgery, even, there's quite a bit of variability about what minimally invasive means. And so I would encourage patients to ask their doctor what they mean if they use the term minimally invasive. For me, it's kind of an idea that we would like to disrupt as little amount of tissue as possible in order to fix a problem, whether that means using a small tube and a microscope to operate, or whether that means taking a different approach to the spine, perhaps through the side as opposed to splitting the muscles in the back. But those concepts can also be applied to functional neurosurgery and also to brain surgery, right? So we use a 3D navigation system to minimize the size of our bone drilling and craniotomy. We use that system also to localize the tumor so that we disrupt as little brain as possible and find the best approach to resecting brain tumors or approaching aneurysms like Dr. Snelling would do. And then in the realm of functional neurosurgery, again, some procedures can be done with just a needle, and some of them do involve a little bit bigger of a surgery. And so I think it's important for patients to discuss with their doctors what exactly is meant by minimally invasive neurosurgery, and then what are the other options. Minimally invasive neurosurgery is not the best option for some patients.
You know, we are entering, or we have entered really, over the last, I would say, 5 to 10 years, into a new modality of the presentation of healthcare in general. There's the whole issue of collaboration, interdisciplinary communication, which really gives tremendous value back to the folks who are viewing, because it's no longer just one person doing what one person thinks should be done or is capable of doing. It's the combination of, I mean, I'm just looking at two of you. I have to imagine that there is some a collaborative relationship on some of the problems that are presented to both yourself, Dr. Snelling, and to you, Dr. Miller. Am I correct?
Absolutely. I mean, even though Dr. Snelling and I are both neurosurgeons, he has expertise that I don't possess and vice versa. So we work together very closely, not only the neurosurgeons together, but we have a multidisciplinary team at the Marcus Neuroscience Institute and also at Boca Raton Regional Hospital, where we work with pain interventional physicians, we work with medical neuro-oncologists, radiation oncologists, general medical oncologists, and each other to treat patients as best as we can. And the nice thing about having that center is that we can keep everything kind of in-house. I mean, I personally have the cell phone of everybody that I work with, and we text each other daily with updates and questions, and that collaborative effort, I think, is very important for patient care.
Well, you mentioned something before you get into it, Dr. Snelling. In essence, what people don't realize is that in hospitals of yesteryear, although a good portion of that is still with us, the grand rounds method of communicating with one another has been altered quite a bit. Just with what you just said, communicating through either your cell phone or through your Surface Top or whatever it is. Mm-hmm. I mean, the immediacy of when possible, of having additional support, intellectual, medical support, I think is very, very important.
I completely agree. To Tim's point, for a long time, especially in the field of neurosurgery, we sort of existed in a silo of our own specialty care. And one of the things that we've tried to do at the Marcus Neuroscience Institute that goes along with a more general theme of collaboration is that, as he mentioned, we not only collaborate with the other neurosurgeons at the Institute, but neurologists as well. In this field of neurosurgery that I specialize in, which is endovascular neurosurgery, we certainly collaborate with not only the vascular surgeons, but also the other radiologists. An example of that would be, in my field for a long time, we used catheter-based techniques to treat blood vessel disorders in the brain. And we typically go through the artery in the leg because that's what's familiar and that's what's common. But because we existed in our own silo, what we didn't realize is that the entire field of cardiology had switched from using the leg as an access site to using the wrist because it's much safer to patients. And so through that understanding and that breaking out of that silo, now the field of endovascular neurosurgery has begun to move towards what cardiology has already established. So that's one example where we're at the Marcus Neuroscience Institute, we're sort of leading that collaborative effort to break out of that silo and provide the best patient care possible.
You also mentioned, Dr. Miller mentioned, now your surgical, your ORs, all right, operating suites, are quite different. I mean, they're not just dedicated to your surgical technique, correct?
Correct. The operating rooms that we currently use are perhaps the most state-of-the-art operating rooms in the country with regards to neurological surgery. We have MRI machines and CT machines that actually hang from the ceiling. We can actually roll them into the room, get an MRI during a procedure. As Tim had alluded to, we have the most sophisticated sort of GPS systems for the brain that allow mapping of the brain during surgery. Not to mention the most state-of-the-art systems for doing endovascular procedures. So we really have all of the, again, through the generosity of the benefactors to the hospital, we have all of the state-of-the-art tools necessary to do these procedures, and that's another sort of added benefit.
One of the areas, and again, it's not limited to this, but we got a lot of questions about the issue of aneurysms. Mm-hmm. Could we touch on that, either one of you?
Sure. Aneurysms, brain aneurysms, are essentially weakening of the blood vessel wall, of an artery of the wall. And there's not an exact understanding of why that occurs. There's probably some genetic history, sort of a family history component. But there's also other things that can predispose people to develop aneurysms, such as cigarette smoking, alcohol use, high blood pressure, things like that. The problem with aneurysms is that they are essentially silent until they rupture. And when they rupture, they can present as a devastating type of stroke that can have a risk of death, can have a risk of serious neurological injury. So as someone who treats aneurysms for a living, sort of the challenge is how do we identify patients that may be at a risk for having an aneurysm, and how do we treat them before they rupture? And that's something that we've currently enacted upon at the Marcus Neuroscience Institute. Again, it's not only identifying those patients, but when we do identify patients with aneurysms, because they usually are clinically silent, we try to treat them before they rupture and before they cause serious neurological injury.
And again, to either one of you, is there some genetic predisposition? I mean, I know when you do, histories relative to your patients, I guess the question must come up, has anybody in your family ever had an aneurysm, et cetera?
Certainly.
Am I correct?
So exactly. So that's really what it boils down to. Family history is the poor man's, genetic analysis. So what we usually ask patients is, do you have a family member that's had a history of a brain aneurysm? Do you have a family member that died suddenly of a bleed within the brain, or do you have a family member that's had an aneurysm rupture? And what we usually tell patients is that they have a relative that's had that, they're at an increased risk of not only having an aneurysm, but if they do have one, having that aneurysm rupture. And those patients need to be, evaluated and possibly treated before that rupture happens.
And to either one of you, what is the style of treatment?
So it really comes in two flavors. One, as a neurosurgeon, is the traditional form of aneurysm treatment is actual surgery, where a craniotomy is performed, the natural sort of corridors of the brain are maneuvered, and a clip that looks like a clothespin is placed across the aneurysm to prevent blood from flowing into the aneurysm. If blood does not flow into the aneurysm, then it cannot rupture. More recently, as I had alluded to previously, there's what we call endovascular procedures, or catheter-based technologies that allow you to access the arterial system or the highway of the arteries from a remote site, perhaps the artery in the leg or the artery in the wrist. And you can take these catheters up into the brain, and you can put small devices like platinum-based coils or a stent to exclude that aneurysm from the circulation and prevent it from rupture. So a big field, the neurosurgical field of aneurysm treatment, has really shifted from open surgery, again, to a more minimally invasive way of treating aneurysms, which is through catheter-based techniques.
Do I assume that that stents are to what your subspecialty is right now, as to what it has occurred in cardiac care?
It's extraordinarily similar. The field of brain surgery for aneurysms and for stroke prevention has really shifted to more catheter-based techniques, similar to how cardiology shifted away from open heart surgery to catheter-based procedures for stent placement and things like that. One thing I would caution you, though, is as there's still open heart surgeries being performed, cabbages and things like that, there's still certainly a role for neurosurgery in the treatment of aneurysms. So one of the things that we do offer at the Marcus Neuroscience Institute that's really only able to be offered at a handful of centers in the entire state of Florida is the ability to provide the entire spectrum of treatment options. If you come in for an aneurysm, we're not just going to treat it with catheter-based techniques because that's all we have. We're going to give you a personalized treatment plan that works best for you. And in some patients, that is actually surgery.
So, Dr. Miller, let me get back to you, because one of the most queried issues from our viewers is spine surgery.
Mm-hmm.
So let's talk a bit about that, because I'm not going to get into the namings of these things, but there's so much television advertising about spine surgery with a little Band-Aid going over this and that, and I'm not going to get into it, but talk to me about spine surgery.
Well, yeah, spine surgery, in my mind, can be done for a lot of different reasons, right? So scoliosis is one reason. That's a curvature of the spine, abnormal curvature of the spine. Degenerative disease is another, where either the joints or the discs of the spine break down. Instability is another reason to perform spine surgery, where the bones that stack up on top of each other normally have slipped on each other. We call that spondylolisthesis. And then nerve compression is another one, or spinal cord compression. So that would be any situation where a nerve that travels down to the leg is being compressed by a disc or by joint overgrowth. And then I suppose another side of this would be for things like tumors, right? And so those are bigger surgeries typically, but those are kind of the indications for spine surgery in general. Again, I think going back to the patient's history, talking to them about their symptoms, extremely important, right? So not every patient that has back pain has an instability that needs to be fixed with surgery. A lot of patients can have back pain from muscular spasms, from arthritis of the back. And so I would, caution people to really talk to their surgeon or talk to their pain management specialist or neurologist, whoever they're meeting with, about what kind of pain they have, what makes things better or worse for them, what sort of things have they tried in the past. Certainly for a new patient that comes to me with like a complaint of back pain or even a nerve pain, I'll ask them what sorts of things they've tried, because surgery should never be the first line option, or should rarely be the first line option. Really, an exhausting of conservative treatment options is important, specifically to me, in treating a patient, because if something can be done without surgery, it should be.
Just what you just said is very interesting, because the communication was that there is so many different reasons why you might have that spasm or that pain, which is not necessarily modified or, shall we say, dealt with by a surgical intervention. The issue on functional neurology, again, let's get into that a bit, because there is a lot of questions about that also. Please.
Sure. Functional neurosurgery focuses really, it's a broad category, but it focuses really on three things: epilepsy, movement disorders of the brain, which are addressed and on the surgical side with mainly deep brain stimulation, but also some other treatment methods, and then pain. Okay, so this is kind of the way that the nervous system functions, and that's why it's called functional neurosurgery. My focus is pain functional neurosurgery. I do deep brain stimulation as well, and we're building an epilepsy program as we speak, which really starts from the neurology side. They initially will evaluate a patient with epilepsy or seizures, and eventually, if they are deemed to be a surgical candidate, will come to me or another functional neurosurgeon. On the side of pain, this kind of has to do with things that can't be anatomically explained. Like a patient has had, say, a ruptured disc that pressed on a nerve going to the leg, and that ruptured disc is addressed surgically, but the patient still has pain. The way that we can address that is with something called a spinal cord stimulator, which I think of kind of as a pacemaker for the spinal cord. What it's meant to do is to block pain transmission or overshadow pain transmission with a different sensation, or to block those pain signals altogether from traveling up from the back, their legs, even the flank, sometimes the chest, or even the face, to be transmitted to the brain so that you don't have a sensation of pain.
Well, that's interesting, because again, pain issues are sometimes, shall we say, inappropriately, and that's, I guess it's my editorial comment, dealt with. Just the writing of a particular prescription for a pain reliever, and unfortunately, there's been so much overutilization of products that are opioid in nature that there is an answer to many of those pain issues. And I don't blame anyone who's a pain, specialist or whatever, and I certainly don't believe that non-professionals should be involved in telling doctors what to do. Mm-hmm. You're the licensed healthcare providers. We need to depend upon you, rather than somebody in the political realm just offering their comments because it's being referred to them by some kind of headline. And I certainly understand the opioid issue, and like I said, my first profession was pharmacy, so I understand it. But it's very interesting as to what you just said, because I really think that people don't realize what can be accomplished by someone like yourself who deals with functional neurosurgery.
Well, thank you very much. I completely agree with you, and I think we've seen this come to the forefront of both national and statewide news, where more people are dying from opioid abuse or over prescribing than we're actually benefiting from it. we've seen state laws be enacted and federal laws in terms of how much narcotic pain medication I can prescribe or a pain management physician can prescribe. We've seen regulations on how those medications are given out to patients, and then what patients are supposed to do with them if they run out of pain medication, or if they have leftover pain medications. We now have centers where those can be disposed of properly. So opioid abuse and opioid overprescribing, I think, is on the forefront of kind of everyone's mind right now. That is certainly one of the aspects that we like to address with functional neurosurgery, is trying to reduce patients' narcotic requirement, and that's a kind of a secondary benefit to pain relief. Where we can treat patients with a small procedure or a spinal cord stimulator or other treatment options where they can then come off of narcotic pain medications, and that's great to see. Certainly the pain management physicians that I work with closely have that same mindset, where they don't want to be prescribing long-term narcotics for patients, both because it doesn't really work all that well. Patients still live with pain, they just have to take more and more pain medication, and also because I think now there are better options.
And again, I don't want anyone to feel in the audience that people who have the ability to establish policy are doing anything that's wrong. They're just trying. They're trying to reach out and say, you know, let's stop the advancement or the overprescribing or the inappropriate prescribing, et cetera, et cetera. I understand that. But I wish they, for those folks out there, I wish there were more functional neurologists who were perhaps in the discussion to make those decisions, and I'll leave it at that. I shouldn't get into the editorial comment, but I did. So, Dr. Snelling, very quickly, with reference to, I'm getting back to the issue of what these people know as a rupture of a blood vessel. Mm-hmm. All right. There are a lot of people who have asked questions about abdominal aneurysms.
They can be related. Certainly, abdominal aortic aneurysms fall under the specialty of vascular surgeons, who are able to, again, bring that sort of full gamut of treatment options, from open surgery to catheter-based or endovascular techniques. You know, they probably have a similar genetic underlying mechanism, just like brain aneurysms, which then you combine with high blood pressure and smoking and alcohol use, which may cause the aneurysm to get larger and burst. You know, one thing to bear in mind is that aneurysm rupture is, you know, what we call a hemorrhagic stroke, or a bleeding stroke within the brain, and that makes up about 1/6 of all strokes. The other 5/6 of strokes, which is the majority, are ischemic strokes, where a piece of clot comes from the heart or from the neck and it gets lodged in the brain. So that's certainly the most common type of stroke, and it's extraordinarily devastating. You know, stroke is the 5th leading cause of disability in the United States, and that's certainly something that we're also able to treat. So we can use catheter-based techniques to actually go in and very quickly retrieve the clot, pull it out of the blood vessels of the brain, and restore normal blood flow to the brain within a matter of minutes. And so we can save brain that way.
Well, we're down to the last couple of minutes of the show, so I'm going to give each of you a minute to really let me have it. So it's your time.
Well, I think I would just emphasize the multidisciplinary and almost kind of a small academic field that we have at the Marcus Neuroscience Institute, as well as the Lynn Cancer Center and our Women's Center. These things are all on our campus, and we all work very closely together to address patients with all types of issues, not only neurosurgical or neurological issues, but cancer, pain. We've seen cerebrovascular disease. There really is no reason that a patient would have to leave our center. I mean, if they come in with any number of issues, we can treat everything there. I think that's a recent development in our center, where we now have experts in cerebrovascular surgery and functional neurosurgery. Our medical director, Dr. Frank Vrionis, is a skull-based surgeon. He does a lot of tumor oncology as well. We have spine surgeons also that work with us. I do that myself, as well as Dr. Snelling. The fact that we work together, I think, is great for patients. A lot of times in kind of smaller private practice communities, even a neurosurgeon can be kind of fragmented away from the rest of his practice and doing surgeries alone that maybe would be better served for the patient to be done together. I know Dr. Snelling and I work together quite frequently, at least several times per month, to treat patients with larger surgical needs, such as an open back surgery for a tumor resection or removal. We do that together to minimize the time that the patient has to spend on the operating table.
Well, Dr. Snelling, you have one half of a minute.
Perfect. You know, I just want to echo Tim's sentiments. The days of what I would call the country neurosurgeon or the community neurosurgeon that sort of treats all of neurological disease is sort of that's sort of come and gone. One thing that we offer at the Marcus Neuroscience Institute is that collaborative effort that allows neurosurgeons who have subspecialty trainings, fellowship training, to then tackle that specific part of disease. And then when we realize that there's something that one of our colleagues is a specialist in, then we allow them to tackle that. So that's something that certainly you see at big academic centers, and that's certainly something that we offer at the Marcus Neuroscience Institute that you're unlikely to find at other places.
Well, the founder of our program, Dr. Morton Terry, who was an internal medicine cardiologist and did nuclear medicine, always felt that in order to educate a doctor, you have to make sure that they understand that they have to respect their fellow colleague, whether they are in the doctor registered field, or whether they're a pharmacist, or whether they're a nurse professional, or whether they're a physical therapist, whatever they are. Respect is part of collaboration, and collaboration only brings value to those folks that are out there. So thank you both very much for being here.
Thank you.
Do good work. I'm sure you will, and thank you once again. We'll have you back too. This is a very interesting thought. Folks, I hope we brought to you some answers to your questions. Remember, if you have any further questions or comments, there's an email address here and a telephone number. Be sure to use it. And like I always tell you, this is your show, so if you have any other subject areas you want us to talk about, let us know. Once again, this program is called Dateline Health. Make sure you take good care of yourself. My name is Fred Lippman. We come to you from Nova Southeastern University. Until next time, see ya.